Hello, everyone. Good afternoon. Thank you so much, everyone, for coming. It's great to look out and see so many friendly faces on a Saturday afternoon. I'm Cassie Adams, Care Services Director with the ALS Association, Oregon and Southwest Washington Chapter, and this is our annual ALS Research Symposium. We have a lot of really great speakers for you today and a Q&A at the end. Just a few housekeeping things to take care of before we get started. If you're interested in connecting to the Wi-Fi on your phone, it's a open OHSU guest, and there's no password. If you have any questions, you can flag one of the staff members down to help you out. We have some cue cards or cards on your tables. If you have any questions that come up through the presentations, we are not going to be taking any breaks, and we're going to have a Q&A panel at the very end. So feel free to write any questions down as they come up, and you can give them to some of the staff members to be asked at the end. We also will have roaming mics, so you can ask questions as they come up at the end as well. For those who are live streaming at home, unfortunately our question link is not working, but if you have any questions about the presentation as you're watching from home, feel free to email myself or one of the staff members, and we will do our best to help get you answers at a later time. And lastly, very important, snacks and refreshments are at the back. And we encourage you to get up, stretch your legs, go out and use the restroom if you need to throughout the presentations, as we won't have any breaks. And restrooms are just right outside of this room, and you'll make a left, and there's men's and women's located right there. We also have additional restrooms on each of the floors, so you can take an elevator down if you need to. I would like to thank our sponsors today. Thank you to Hayek Medical, Ability Center, Mitsubishi Tanabe Pharma America, ITF Pharma, and Permobile. And also a huge thank you to Oregon Health Sciences University for helping us to put on today's event. And a big thank you to Providence Brain and Spine Institute for being here and for the clinical research that they do. Without further ado, I'm going to bring up our Executive Director, Lance Christian, to introduce today's speakers. Thank you.
Good afternoon, everyone. Can you hear me? Great. Oops. There we go. Great. I'm Lance Christian. I'm the Executive Director of the ALS Association, Oregon and Southwest Washington Chapter. Our mission is to support the efforts to find treatments and a cure for ALS, while we also provide compassionate care and support for families living with ALS. We serve the entire state of Oregon and Southwest Washington, and as part of that effort, a nationwide effort, we're part of the National ALS Association. And through that community, we support and fund ALS research. The ALS Association Treat ALS program is the largest nonprofit funder of ALS research in the world, last year funding close to $20 million in ALS research. And how that happens is support from across the country, including from here in Oregon, gets pooled together to fund interesting and unique science for translational research and basic science purposes wherever the best science is being done. And so literally at any one time there are around 130 different research projects being funded across the United States, Europe, Asia, South America, and even a recent grant in South Africa. So you can say when you support our research efforts, the sun never goes down on our efforts to find a treatment and cure for ALS. Locally here, I'm really proud to share that besides our normal yearly contributions, since 2012, our chapter has rallied to provide over $1.2 million in additional funds for ALS research, including supporting a large research grant to Dr. Joe Beckman, one of our speakers today. So all of this means that really since the Ice Bucket Challenge, and I know some of our speakers will talk about this, there's been a phenomenal amount of activity in the last number of years. My tenure, I've been with the ALS Association 16 years, and I'm more excited now than I've ever been before because we've seen amazing amounts of new researchers, cross-pollination, more papers being presented, more research happening than ever before. Since the ALS Ice Bucket Challenge, 5 new genes have been discovered, and the energy is pretty remarkable out there. We used to come to conferences and the neurologists would be discouraged, but now what I hear is hope. And so with that today, we're excited to have some amazing presenters. We want to thank them for their time and their dedication for their work. And I'm going to present them, introduce them, and then be thrilled to have the opportunity to learn from their experience and the cutting edge things that are happening out there in the world. So our first speaker today is Dr. Chafic Karam. He is the Associate Professor of Neurology, School of Medicine at Oregon Health Science University. He did his residency at Beth Israel Medical Center, Albert Einstein College of Medicine in New York. He did fellowships at Mayo Clinic and Mass General Brigham and Women's in peripheral neuropathology and neuromuscular medicine. He's a member of NEALS and the American Academy of Neurology. And I want to share his center participates in many clinical trials. He's a frequent collaborator across the United States and speaker at other organizations and other chapters. So please join me in welcoming Dr. Chafic Karam.
Okay, thank you, Lance. I'm going to first start by thanking Lance and Cassie for the effort that they do and for putting this symposium. I think it's very important for our patient and caregiver to listen and see what's going on.
Look, see where you're at.
Okay. There you go. I have to stand here. And also I can see myself. All right. That's very embarrassing. Thank you. So thank you for doing this, and thank you for being able to invite outside expert. Especially a big thank for Dr. Harms. I just realized, and my wife reminded me today, that tomorrow is Father's Day. And Matt had 3 daughters, and he came here, and I just realized that you miss spending tomorrow with your daughter. So thank you very much. And also thank you for Dr. Anstrud, who I was first assigned to give an hour talk. And I was like, I cannot talk for an hour. People are going to fall asleep. So I decided to invite Dr. Anstrud, who's going to fill another half an hour, and he's a great speaker, and he's going to wake us all up after this. So this year, Lance asked me to talk about frequently asked question in patient and people with ALS and their loved one. And I try to remember a little bit what questions come up frequently. I also asked Ivel, our awesome nurse, what questions do patients ask her? And she's sitting there. Thank you very much for coming. And we came up with a list of different questions. Of course, unfortunately, ALS is a terrible disease. And one of the biggest questions is, what is the prognosis and what's going to happen next? So we're going to try to talk a little bit about this, although it is a kind of a delicate question, and I do feel a bit uncomfortable saying it and going in all the details. But I think it's important for people to be able to plan their life and talk with their loved ones if there are things that they want to do on their bucket list to be able to do it. And I think one of the major implications, about 3 years ago, one of my patients with ALS unfortunately passed away, and then I called their spouse and asked, how was your experience? What could we have done better? And the main thing they said was, I wish you kind of told us better and stressed out more how much time we had left, because we would have loved to do some stuff. And although a lot of time we do discuss the prognosis early on in the disease, it's when we announce the diagnosis, it's a flood of emotion, and it's hard to really remember every details that we say. So that stayed in mind, and I try now every time that I see somebody with this terrible disease is to kind of just talk about how things are going, how the plans are going, how the progression is going on, and so forth. So the next question is, of course, the medication for ALS. Unfortunately, there's no cure yet for ALS, but there are a couple of medications that I'll talk a little bit about. Supplements is a big thing, and whenever we don't really have a good treatment, supplements come in mind. Diet, exercise, as I mentioned, Dr. Anstrud is going to be talking about those. Stem cell therapy is a very frequent question, and then we'll talk a little bit about available clinical trials here in Portland and Oregon that if somebody's interested can participate in. So prognosis, this is a graph that shows you a group of people with ALS in a single ALS clinic, how they progressed over time. And each of these lines is a patient. And as you can see, it's highly variable. So some people, unfortunately, progress within 12 months, and some other lived 84 months and longer. And we know in our ALS clinic that we have patients who unfortunately progress over 6 to 12 months, really rapid progression. And we have other patients who live 10 years, 15 years, and even longer. So ALS is a heterogeneous disease, and really we always say that the average is 3 to 5 years of survival, but this is an average, so this is combining hundreds of patients, and it really varies from one person to another. And the reason this varies is we know that, for example, age, the younger people are, usually they tend to do a little bit better. Site of onset, so if the disease starts in the arm or in the leg, they tend to do a little bit better than if they start with the what we call bulbar, which is the speech and swallow muscles. Delay in diagnosis. So this is a good thing. So if the diagnosis is delayed, usually it means that disease is progressing slower, and that usually tells us it's a little bit better prognosis. If the breathing is involved early on, that's not a very good thing, because this is really what is the main reason why the disease progresses. The presence of dementia is also not a very good thing. Typicality of ALS, so if there's anything that is atypical, that doesn't really look a lot like ALS, that's usually a little bit better prognosis. Weight, people who are malnourished and underweight don't do as good as people who have normal weight or are a little bit overweight. And then finally, genetic mutation. We know that certain genetic mutation can cause rapidly progressive disease, and some other cause a kind of a slower progressive disease. And Dr. Harms is going to talk a lot about the genetic of ALS later on. So in order to kind of better understand the prognosis and try to do prediction model, the European Network to Cure ALS, which is a group of ALS center, kind of the equivalent of NEALS here in the US, came up with a study. They collected data on thousands of patients and tried to divide patients into kind of slow progressor and rapid progressor, and come up with a way to try to understand a little bit how the disease progresses. And they come up with a tool. It's an online software that can, if you input data, it can kind of give us an idea how things will progress. And it's not a perfect tool, and there's no way to predict 100% accurately how things are going to go, but it gives us a good idea. For example, you can see in this, when we input the data, it gives us kind of a survival curve. And there's a good standard deviation, if you want, so 24 to 36 months, so 12 months is a lot, but it gives us an idea how things are going to go. And if patients are really very interested in knowing their prognosis, we sometimes use this tool. Now, going to the cause of death, as you probably know, ALS most of the time will progress to involve the breathing muscles. And this is unfortunately how things progress really fast. And the involvement of breathing kind of impairs not only survival, but quality of life. And this is one of the reasons why we really emphasize the use of non-invasive ventilation. And probably one of the best intervention that we do in our clinic is do a good teaching about breathing and BiPAP and the importance of starting that early on. It is uncomfortable, having air being pushed in your mouth and throat. It's really not a good thing. But I think if we start using it maybe a few minutes, and then a day, and then a little bit more later on, and eventually we can use it for a couple of hours or even longer, that would be a good thing. It does affect quality of life. If your brain is lacking oxygen when you sleep at night, your waking up tired, you're not in a good mood, you're fatigued, you don't have the energy to do a lot of things. But if you are getting the oxygen you need during your sleep, you usually tend to do much better. And not only the quality of life is much better, but the survival probability is increased as well. Now, the next common question, medication and supplements. As most of you probably know, the FDA currently has 2 drugs approved for ALS. And these are the drugs that also are used elsewhere in the world. Riluzole, which has been with us for over 20 years now, and edaravone or Radicava, which has been approved a couple of years now in the US. Riluzole is a little bit, I never really know how to say it, Riluzole or Riluzole, but it's a pill. It's taken twice a day, and it has been shown in many clinical trials to prolong survival by a few months. So it's not it's not going to stop the progression of the disease. It's not going to reverse it. It's not going to cure ALS, but it does add a few months. And this is one of the most recent study looking at when it does add a few months, and it's really later in the disease. So I tell patients, if you want to take it, it's good to take it. The major side effects is some GI disturbance, and we have to monitor the liver enzyme because very rarely it can cause liver toxicity, but usually we see a trend, an increase in the liver enzyme, and we can usually stop the medication. Some patients don't want to take it or get side effects, and that's totally fine. It's not something that you have to do, but if it does add a few months. The other drug, edaravone Radicava, is a little bit more complicated. It needs a much longer discussion. One of the major reasons is because it's an infusion medication, so it's not just a pill that you can just do on your own. The infusion is usually every day for 10 days, every month, and because of that, you either have to go to an infusion center or you have to do it at home. You have to put a port and so forth. So it does require a lot of planning and energy. The other thing is that the data on it is, kind of controversial. And I see Mitsubishi Tanabe is there. They always come after I talk and tell me why you say that. But, I have to go by the science. The first study that was done was negative. It has a large number of patients. And then the second study that was done had a lower number of patients, was much more selected kind of criteria, restrictive criteria, and that showed at the end of 6 months of trial there was a change in the ALS-FRS score. And I can go in a lot of details in this, but again, this is an option that I tell the patient if they want it, good. If they don't want it, don't stress about it and don't worry about it. So now we go to supplements. If you Google supplements and ALS, you have over 29 million results. And I'm not going to talk about all these, but I think a good way to really address this is what the ALS Untangled group is doing. And anybody can access this website. ALS Untangled, Dr. Bedlag was here 3 years ago. Lance invited him, and he gave a great talk. He's a big fan of X-Files, and he always has flamboyant dress code. But really a great effort, because they really take medication, supplements, or drugs, or different ways of intervention, and they study it and see whether there is evidence or there's no evidence. And they classify the evidence whether we just don't know, so more research need to be done, or there's evidence that we know that it doesn't work, or there's good plausibility that this actually could work. And a lot of time this will go on to go in clinical trials. There's many different papers written so far, and most ALS experts participated in some of these projects. And as you can see, you have the mechanism, the preclinical cases, trial, and risks. And I think the most important is always to look at the risks first, and F is bad. So you have over 5% of either significant side effects or death because of the intervention. And this one goes to stem cell transplant at the hospital San Jose Tecnológico de Monterrey. So don't go there. Other things, the U is unknown, and as you can see, the trials, most of them are unknown, so we just don't know. Some of them are For example, hyperbaric oxygen, there's been a trial and it's been negative. Antiretroviral, there's been a trial and back in New York, and that was negative. But there are more newer trials right now going on in antiretroviral, and I think it makes a little bit of sense. So all of these, you can actually access it for free and click and read the paper and make the conclusion that you like. But they also write a conclusion as well. Not only that, if you're interested in knowing more about certain compounds or certain medication, you can go and vote. And the medication that gets the highest vote usually has a priority for review and studying. So, and you can also suggest medication as well. So that being said, I'm not going to talk in details about every supplement. That will take us days. But overall, most of the supplements, multivitamins and so forth, unfortunately, don't have good evidence that they actually help. We studied vitamin D in the past, and that could have some benefit, but we really don't have any good proof. Vitamin E has been studied extensively. Again, no good proof that it actually does anything. Apart from people who are at risk of developing ALS, then there are some suggestions that if you take doses of vitamin E, it may delay the onset of the disease. Another common supplement that is taken is CoQ10, and it's a little bit expensive, but again, no good proof that it works, and so forth. Now, the reason why I'm talking about this in detail is because just this week I saw a patient who told me, I'm very excited for the symposium this Saturday. I hope you're going to talk about L-serine. I was like, no, I didn't have it, but now I have to put it. So this is a special request, and that's why it's there in a little bit more in detail. It actually has some interesting thoughts behind it. So L-serine is an amino acid which your body can actually make, and you can also buy it, and it's cheap and it's widely available. And the reason why there's a thought that it may work in ALS is because back in, was it in the 50s or 60s in the Guam Island Pacific, there was kind of a breakout of ALS plus Parkinsonism. And there was many theories of why this happened, but one of the things that got implicated was BMAA, which is found in the food that the indigents there used to eat. And L-serine can actually stop the toxicity of BMAA. So it was thought maybe we can do that in high dose, and that can stop the disease. One of the issues is that when you do autopsies on these patients, we don't find high dose of BMAA, although we know that BMAA is toxic to the motor neuron. So, and of course, L-serine has been reviewed by the ALS Untitled group, which concluded that it's unclear if it works, and there's really need for other trials. There's been one trial that looked at 15 grams twice a day, so kind of high dose, and they didn't find any significant toxicity. So it's probably safe, and there's an ongoing study right now, and see what that will go. So this is my just 2 slides on L-serine. And now diet is another big thing that is talked about in ALS, and we know that people who are malnourished, who are very thin, tend to do a little bit worse than people who have good weight and who are a little bit overweight. Unfortunately, we don't know what type of diet is good for ALS, so some people think high carbohydrate, some other people think ketogenic, but we don't really have any strong proof that one is better than the other. My thought on that is that, you know, if you like something, just eat it. So I think that just eat whatever you like to eat, but at the same time, don't force yourself too much to kind of gain weight or something like that. Because a lot of people spend a lot of energy and time trying to gain weight, and I think you should just do what feels right to you. Exercise, hopefully, will be, thankfully, not hopefully, will be covered by Dr. Anshrud. And then we'll talk a little bit about ALS progress in clinical trials. You know, unfortunately, there's over 50 clinical trials that have been completed now with ALS, and we still don't have any cure. However, I think things are going to change soon. And one of the reasons is And that's, I think, I'm very happy that Dr. Harms is here because genetic therapy and modification of gene expression and RNA is real. It's no longer science fiction. Actually, in my clinic right now, I use 2 drugs in other diseases, not ALS, but in other genetic conditions that actually have shown to improve dramatically the outcome of patients. So this is real. The problem is that most ALS is not linked to genetic mutations yet. But about 15 to 20, and Dr. Harms can update us later, I think about 15 to 20% of patients with ALS will have some sort of genetic mutations. And when we have a genetic mutation, we have a target. And it makes sense to go and work on that target and try to fix the gene or tell it to stop expressing itself. And this way we can stop the disease from happening. So I think this is, to me, the most promising things going on right now. And that's why I put a lot of weight and importance on what Dr. Harms is studying. And as you can see, you know, for many years, the only gene that we had was SOD1. And then just in the last 5 years, there's over 30 genes that have been discovered. And I just heard last week you discovered a new gene, I think, or a couple of weeks ago. So it's just amazing how things are going so fast. So what is the, and I'm not going to dwell on this a lot because I think we have better experts who are going to talk about this. But this is very, very simple. Basically, you have a gene that is coding for a protein that's causing toxicity to the nerves. And what we do, we just send an antisense oligonucleotide that just attaches to the RNA and tell the gene to stop expressing itself, and the protein is not expressed. There is currently a trial in SOD1, and it's currently active and enrolling. And Providence will be a site for this study. So just last week, we diagnosed a new patient with SOD1, and we sent him to San Diego because they're doing the study already there. But once Providence starts, we're going to transfer back, and I think you can talk to the Providence team here who can talk more about this treatment. But I think this is very promising, and I do encourage every patient to, if they have genetic mutation, to participate in those trials. There's also a trial going on for C9orf72, which is much more common than SOD1. As Lance said, there's over 100, and I have 5 minutes, almost done, over 100 clinical trials going on in ALS at any time. So this is really good news. We've recently stopped enrolling for the Amylyx trial, which is run out of Mass General, and we're just going to wait to see what the results will show. We also recently stopped enrolling for the cytokinetics trial, which unfortunately was negative, but has some promising things, and I think the company will move forward to do more studies on that, and then we'll have updates for the copper with Dr. Beckman a little bit later. So I think the last question, and one of the most common questions, is stem cell treatment. And you know, stem cells sounds good. You know, sounds like something that could, I don't know, attractive, like science fiction almost. But if you think about it, what is stem cell? They take cells that kind of have the possibility to differentiate into different things, including motor neuron, if you want, and put them back in the human body. There's 3 main ways to do it. One of the ways is to inject it in the blood. Unfortunately, when you inject the stem cell in the blood, they go to the lungs, they go to the kidney, and they stay there, and they don't go where we want them to go, which is the spinal cord and the brain, because that's where the motor neuron live. So that's not a very good strategy. Unfortunately, there are a lot of clinics everywhere that do that, but probably doesn't work. The second way to do it is to inject directly these stem cells in the spinal cord or in the brain. However, you can imagine how many times you have to inject to cover the whole spinal cord. It's almost undoable. And the study that was being done is not continuing because I think of that major challenge to do it. And then the third way that I think is the most promising, and we have a phase 3 clinical trial, so very exciting. Phase 3 is when this is the last step of a clinical trial. If it's positive, then usually they would go to the FDA, and if it's negative, that tells us it's a good evidence that it won't work. And we do have a clinical trial, phase 3 right now, where you inject the stem cell in the spinal fluid, and it would go not as good as when you inject them in the spinal cord, but spinal fluid be around the brain, around the spinal cord, and will go. And in general, the idea is not to produce a motor neuron that would go all the way to the muscle, because that will take years, but more to kind of create a healthier environment for the motor neuron to kind of slow down the progression of the disease. So slides courtesy of Dr. Goyal at UC Irvine, who's one of the sites that is running the trial, and we have a few patients who travel from here, from Portland, to there to get the stem cell. So this is moving kind of fast for clinical trials. Phase 2 was rather promising. Data was published, and still data are actually being published even as we talk about that. And right now we are in the phase 3. So it thought that I'm going to go through those. So these are from the phase 2, show promising things going on there, and the growth factor and kind of protective factor around the nerves. And these are the sites: San Francisco, Cedars-Sinai, UC Irvine, and Mass General, UMass, and Mayo. These are the inclusion criteria if anybody's interested in this trial. Less than 60 years of age, breathing function more than 65%, less than 2 years of ALS, and kind of progressing, not people who are not progressing. So the good news is that they expect that in mid-2020 we'll have some results to tell us whether this actually works or not. And I think if it works, it will kind of quickly move to a clinical practice and commercialization. So this is, I think, my last slide. It's about what's going on right now at Portland and OHSU and Providence. We have the Orion, which is mainly a pill that you take. It makes the muscle a little bit contract, a little bit stronger, and the main outcome is the breathing muscle. There's biomarkers going on at Providence. There's deep phenotyping in patients with ALS at OHSU, genomic translation, or GTAC. This is at OHSU and led by Dr. Harms, who's probably going to talk a little bit about it. And as I mentioned, the very exciting SOD1 that is going to be happening at Providence soon. So you probably know this from last year. I ended up with the same kind of slide. This is really a very exciting slide to me because it really shows how things have changed over the years. For many years, there was like about 100 publications every year in ALS. However, look at the last few years. It's really, like just last year, over almost 1,700 papers published on ALS. So there's a lot of interest, there's a lot of research going on, and I think this gives us really hope and to continue to try, despite of all the failure we've had, to try to find something that works. And I think right now with the gene therapy, with the stem cell, I think we're really on the right track. So thank you very much for listening.